Right, I think we'll start, will we? Happy New Year, everybody. My name is Catherine. I am co-chair of Quest, the Qualitative Research and Trials Centre based in NUI Galway, and we are embedded within the Health Research Board Trial Methodology Research Network. Some of you may be familiar with the TMRN and Quest. If not, I will let you know about the website later. And I am here to say, first of all, Happy New Year. This is our first webinar of 2020, and I'm here with Nikki Rousseau, who is going to talk on qualitative research about intervention development in the context of the index study. Nikki is currently an academic fellow in the Healthcare Technology Evaluation in the University of Leeds, and she is developing her work on the use of qualitative and mixed methods in health technology development and evaluation. She is leading qualitative process evaluations in several UK NIH or HTA funded trials, and has expertise in using qualitative research to understand patient and clinician experiences of healthcare and healthcare technologies. So we often hear and read about qualitative research in intervention development, whereas Nikki is focusing something which is less common, which is qualitative research about intervention development. So you're very welcome, Nikki. I'm going to mute myself and hide for the next 40 minutes. I'm going to ask anybody who has problems with volume or images or sound to please let us know in the chat button. And also, if you have any questions that come up as you're listening, please put them in the Q&A section. I'll collate those and I'll pose those questions to Nikki at the end of the webinar so as not to interrupt her, if that's okay. And any other questions, let me know. Okay, thanks, Nikki. I'll hand over to you now.
Okay, thanks very much, Catherine. So yes, I'm going to talk about qualitative research about intervention development, focusing in particular on the index study. Although I'm going to give an introduction to the index study, overall, I'm going to focus particularly on the qualitative component, and within that, particularly on the papers that we wrote about design within intervention development. I thought a Quest's audience might be interested in some of the qualitative methods that we use, so I'm going to briefly mention one or two issues that came up there, such as interviewing experts, and I'm going to talk a little bit about qualitative research about intervention development more broadly. So the index study was funded by the UK Medical Research Council, and it was a collaboration between researchers at the universities of Sheffield, Stirling, Southampton and Bristol. And the team was funded to develop guidance to support researchers who are developing complex interventions to improve health or healthcare outcomes. The background to the index study is that, as we know, many interventions in healthcare interventions are not effective when they're evaluated, and even if they are, they may not be implemented widely in real-world contexts. And there's a huge number of reasons for that, which many of you may well be researching. But some of those reasons might originate during the development process. And although there's increasing guidance about how people could and should go about intervention development, we still don't really know that much about which actions and approaches are helpful in producing interventions that are going to be effective. One of the most widely cited types of guidance about intervention development is the MRC guidance. And as many of you all know, this is in the process of being updated at the moment. But at the moment, people are still working with the existing guidance. And that is relatively brief about intervention development, but highlights three areas that there are recommendations for people developing interventions around evidence theory and modelling. Since that MRC guidance was produced, a number of people have conducted reviews looking at the evidence about whether these parts and components of intervention development do help to produce interventions that are effective. And so far, they've in general shown that there isn't a huge difference between the interventions that are developed with theory and the interventions that aren't. Similarly, people have looked at co-production, which didn't feature so much in the MRC guidance, but I think has become much more common in the time since then. And again, there's little evidence that conducting research development with stakeholders will result in interventions that are more effective. That's not to say that there aren't good reasons for doing it anyway, but in terms of its impact, it's the jury's still out on whether it makes a difference. There is a big caveat, however, that there is a very incomplete information about the processes of development, and for example with theory, those issues about how and the extent to which theory might have been used within these development processes, and that's something that I'll be coming back to as I go through this webinar. So the aim of the index study was to produce guidance for researchers on how to develop complex interventions to improve health or healthcare outcomes. And that was the overall aim of the index project. I know that this slide has got quite small text, but it will help me to try and introduce the different parts of the index project. So index started with some systematic reviews, 2 systematic reviews. One was identifying approaches to intervention development, and by approaches I mean published guidance and frameworks, which with the intention of acting as a guide to people who are conducting intervention development. So Alicia and the team did work to identify the approaches that were out there and try and bring those activities together. Alongside that, there was also a systematic review of primary research. So that was teams that had actually conducted intervention development and who had reported about that development and what the actions that they'd taken to produce their healthcare intervention. Then the part that I was involved with was qualitative interviews with stakeholders and with developers of healthcare interventions. The systematic review did feed into that. So one of the ways that it fed into that was the focus on approaches, which we tried to use when we were sampling for our participants. We also tried to interview some of the people whose work had been identified by the systematic reviews. Throughout the index process, the 2 sort of boxes down the sides were really important. So we were taking opportunities right from the start to engage with the research community about the work that we were doing, so conducting workshops, doing presentations, and that was anyone who took part in any of those. That really was important in helping steer and guide the way that the index project developed. Alongside that, we had a more formal expert panel, international panel, who met a number of times throughout the process. And again, they did things like inform the sample for both qualitative interviews and the Delphi surveys. So the systematic reviews and the qualitative interviews all fed into 2 Delphi surveys, again with stakeholders and with developers of healthcare interventions, and all of that fed into the guidance which has now been published. So we've had a busy couple of years, and a number of outputs are available from the study. So Alicia has published her taxonomy of approaches to developing interventions in pilot and feasibility studies. Liz Crute has published her systematic review of the primary studies about intervention development. Because there's a lot happening, they focused on the years between 2015 and 16 for that. The guidance has been published in BMJ Open, and as well as the design work that I'm going to be talking more about today, Katrina Turner has written a paper about understanding successful development of complex interventions, which is available in BMJ Open. I've already talked a little bit about how we were defining some things related to index and the work that we've done. So I've already described how we were defining approaches. Complex interventions themselves, we're focusing on interventions which have traditionally been understood as complex, so things like behavioural interventions, system level type interventions. I know increasingly people are starting to understand that things like drugs and devices in their implementation can be incredibly complex, so they alter the care pathway. They might need additional diagnostic processes, and there'll almost certainly be changes the behaviour of both the patient and people on the downstream, clinicians in the downstream pathway. But we were focusing particularly on those interventions that have more traditionally been understood as complex. The terms development and design are often used interchangeably. However, for the purposes of index, we were understanding development as the whole process of intervention development, from the initial idea through to formal pilot testing, and design as part of that process, where developers are generating ideas for and making decisions about the form, the content, and the delivery of the intervention. So moving briefly away from index to think about qualitative research in intervention development more broadly. So there is a lot of qualitative research that happens in intervention development, possibly more qualitative research in intervention development than in evaluation. So qualitative research is often used perhaps at the start of intervention development study to understand the context of that intervention, to understand the needs and the preferences of stakeholders. I've said usually prior to design, but I know some of the people I spoke to went backwards and forwards qualitative research during the whole development process, and that's obviously, it's great if you can do that to sort of start to find out more about issues that arise as the development unfolds. Something else that I've seen published, although less frequently, is analysis of stakeholder workshops. I think people sometimes get a bit torn about whether that converts a more involvement, co-production type of activity into something where people have become more research participants, and that might be one of the reasons why people don't always do it. But certainly there's published work out there which is looking at activity that happens in stakeholder workshops. Something that seems to happen much less is observations of the development process and interviews with development team members. I've got an example of a team that did do that in a minute. But then when people get to the point where they've got a prototype, qualitative research seems to become much more important again, and often features in assessments of the acceptability and feasibility of those prototype interventions. So one team that did look at, did conduct some observation of the intervention development work that was done by the team, was a team including Finch and Bamford, who developed a cognitive behavioural therapy intervention for fear of falling. And this featured qualitative research in intervention development. So they conducted qualitative research to try and understand the fear of falling problem. And they discovered that it was much more complex than maybe they'd originally thought, as is often the case. And it was very much caught up with issues around the clinical factors that had led to patients being more likely to fall in the first place, which might have been things like postural hypertension, problems with strength of legs, all sorts of things. So that did emerge in the qualitative interviews that were conducted initially, but some of the issues about how that problem became a solution only really emerged during the intervention development meetings. The team, as I understand it, had already decided that they were going to use healthcare assistants to deliver the fear of falling intervention, and because they weren't fully clinically trained. Those people wouldn't be able to engage with some of those underlying clinical reasons why people might be falling. They also wanted to do a tailored intervention, and again, they weren't sure whether those healthcare assistants would be able to deliver that. And there's some really interesting quotes that have came out from intervention development meetings, which elaborate how the problem, the solution, and the interactions between those were worked through. But that's relatively unusual. There's not a huge number of examples of that type that are out there. There has been a limited amount also of research which is looking at across a number of intervention developments and using qualitative research to try and understand what's happening. One team that did do this was Horvath et al. And they were they interviewed people who'd been involved in online health intervention development. And although they drew out some really useful learning, it's quite context dependent. So that I've listed their 7 sort of findings. And although 1 or 2 of them have got wider implications, in general, that they're very much linked to the need to subcontract for part of the web development process. So, because there wasn't a huge amount out there about how people develop interventions in practice, the aim of the index qualitative component was to understand this. How do people actually go about developing complex interventions in practice? And I think the team already knew that a lot more went on than might reach published papers. So we wanted to understand the choices that developers made to use particular approaches, the decisions they made about the actions that they took, and the choices that they made about their actual intervention developments as well. And in particular, we wanted to know about the parts of the development process that they found challenging. And we also wanted to talk to stakeholders, and by stakeholders I mean funders, editors, and people who actually use and implement interventions, about how they felt about the health interventions that are out there and how they are developed. So the sample that we wanted was both developers and, as I say, wider stakeholders. Developers, we wanted to talk to all the people who might be included in intervention development teams. So clinicians, social scientists. I've included PPI as within the developers rather than within stakeholders. I think they can be either, but the people who we ended up including within our study were people who were contributing a PPI perspective, but were integral members of the project team, so they were co-applicants on the grant applications. And we also, as we went along, we identified that we should also speak to designers, and by designers I mean people with a sort of art and design background or product design who have design as their sort of career focus. We wanted to talk to people who were both experienced and less experienced developers, but everybody that we spoke to had developed at least one intervention through to completion. And we also wanted to talk to people who'd had different roles within development teams. We also wanted to have a very wide range of intervention types in terms of both settings, so primary, secondary care, public health, and also interventions that cross-sector. So we talked to people who developed interventions across every health sector and into social care as well. And the scale of the interventions that we talked about was varied from individual behaviour change through to system level changes, and the types of intervention were varied greatly as well. When we set out, we wanted to sample based on the approach that people had taken, so things like theory-led co-production. But in practice, we found that was really hard, because where people might have said that they were going to take a particular approach, in practice they'd often used a different approach, or they had sort of deviated quite substantially away from the approach they'd intended to use. So although we did have some success in using that in our sample, that was really problematic to use in practice. And we wanted our sample to come from both UK and beyond. This is a table of the people that we actually interviewed. We interviewed 21 people, and I think we invited 28 or 29. So we had a really good take-up rate, particularly from people, I have to say, within the UK. We had less success with people that we invited from the rest of the world. That's probably understandable because people within the UK would be more familiar with people within the team and with organisations like the MRC. But we did get a good spread in terms of the other dimensions of our sample strategy. The co-investigators, obviously an overlap between a number of the different categories. Co-investigators tended to be methodologists, the leads tended to be clinicians. Most of our, particularly our senior researchers, also had roles as on funding panels and as editors. I think editors in particular, there weren't many editors who weren't also active researchers, although we did have some people, we did speak to some people who were on funding panels who didn't have any personal experience of intervention development. The qualitative interviews, invitations went out by email and included a questionnaire. Again, I was asking them about the approaches that they'd taken to intervention development, and it mentioned a particular intervention development that the team knew about, but asked them about other intervention developments that they'd taken part in. And that enabled me to do some pre-reading before I conducted the interviews, which then enabled the interviews to focus on the underlying reasons for decisions rather than the participant having to take me through what they'd done with their intervention development. It also felt sort of respectful to use their time appropriately and not ask them to repeat things that they'd already spent time writing a paper to tell people about. We had a topic guide, and that was tailored to each individual, again, partly based on what I've learned with the pre-reading and with the questionnaire. Most of the interviews were conducted by telephone, a couple by Skype, and a couple were face-to-face. The face-to-face ones were both with the PPI contributors at their request. I hadn't, before I did this, I hadn't done a huge number of telephone interviews, and my feeling was that the Skype ones that I did were a more comfortable process. But when I looked back at the transcripts from the interviews, actually with the telephone ones, I seemed to be more likely not to take things at face value, which I found interesting, that what might have felt like it was a comfortable process wasn't necessarily generating the most detailed information. And the average length of time of the interviews was exactly 60 minutes, but there was a range between half an hour and 1 hour 42 minutes. A lot of the people that we wanted to speak to would be people whose names you would have heard of if you're working in the intervention development or health research field more generally. And we wanted people to feel able to be very honest about the sort of warts and all experience of intervention development. We suspected from what we knew that there were bits that didn't always go smoothly, and we wanted people to feel able to talk about that. So right from the start, we paid attention to how we were going to maintain anonymity among our participants. And with the first couple of interviews, that did seem to be, those concerns seemed to be justified. So I had a number of participants who did ask me to turn off the recording at some point so that they could talk off the record, or who revealed things at the end of the interview that I suspect they didn't want to share during the recorded interview. I also had people who asked to review their transcripts and then asked for some of the content to be removed. However, other people said, when I talked to them about it, said that they would have been very happy to have owned their own quotes. And I know that Penny Hoare has carried out a mixed consent model when she's conducted interviews with experts, where people who wish to be anonymous can be, and people who wish to be fully recognised for their contributions can be named. And I think if I was going to do this type of interviews with experts again in the future, I would try and adopt a similar model, because I think it's got some real benefits. But as it stands, we did decide to maintain the anonymity of all our participants, and we did a few things like changing the gender or changing the number of something that was referred to linked to the intervention development to try and reduce the chances that people would be able to identify who it was that we'd spoken to. Just briefly to say a bit about my starting point, as Catherine said in the introduction, I've got quite a lot of experience about process evaluation, and I'm a co-applicant on a number of NIHR funded studies, but I had actually relatively little experience of intervention development before I joined the index team. And I think there were some benefits of both those things. So I understand the health research context, but I didn't come to this with a particular allegiance to any one approach to intervention development. And I think that helped in being quite open to the different approaches that people were using, and also meant that I didn't take for granted some of the things that people might be saying about what they've done in intervention development. I'd also been working quite a lot as an advisor with the Research Design Service, the NIHR Research Design Service, and I felt that intervention development was one of those areas that it was a bit harder to give people clear guidance on as to what they should do with their when they're designing their studies. I wanted to work with the index team because there were some great people involved. There's a picture of them there, and I've just got a general interest in methodology. I like to ask questions about how people do things. So I'm going to move now to talk about the paper that we've written about design within intervention development. I'm talking about analysis now because the other outputs from the qualitative study have used very slightly different approaches to their analysis. So the analysis of the design paper was broadly thematic, although we had elements which don't fit within the Braun and Clark approach to thematic analysis. Probably won't say too much there about other than to say that we started to look for other research and theory as the analysis developed. So we did the initial process of data familiarization and coding, and starting to define themes, and then went out to look for what theories might be out there that might help us to think about and to develop our analysis. So design emerged as a focus of the analysis very early on in the interviews. Right from the start, people talked about other aspects of intervention development, although we had a very wide range of participants in the interviews and a wide range of intervention types. In terms of what people did, a lot of it was quite similar in terms of looking for the evidence, perhaps doing some qualitative interviews, as this quote shows. But when it got to actually using that information and knowledge to produce an intervention, that's when there was a lot more variety, and there seemed to be a lot more challenge as well. So as this person says, they've done some qualitative research, they've got 5 themes, but now they've got to try and turn that into an intervention, and that's where they start to have problems. They're not quite sure how to go about doing that. It's not to say that people didn't have problems with the other aspects of the study. It was quite common for people to say that they identified a lot more literature than they'd anticipated, that sort of thing, but they knew what to do to address those problems, whereas dealing with the challenges around intervention, people seem to struggle with more. Just going back quickly to the MRC guidance, it's very much about identifying information, or so the evidence and the theory, and doing the modelling, but it's not so much about how you actually use that in the development process. So the focus seems to be on the inputs. And again, when people got to the point where they had an intervention, they felt it seemed to be on much safer ground. They knew what to do, how to go about feasibility testing. But that black box, or the function machine as on the slide, that was the bit that people seem to struggle with more. So the findings about design were, as I say, that it seemed to vary more than other actions and was more challenging. When we looked at the data, we tried to make sense of the variation that we were seeing, and we identified what we called 6 modes of design. These modes were not intended to be exhaustive, and they could be overlapping. So one development process might use more than one mode at different times during the whole of the design and development process. And we also identified 3 themes which related to the challenges that differentiated the different design, well, which cut across the different design modes, and the design modes differed in how different challenges related to them. So our 6 modes of intervention design, 3 of these, so the first 3 on the slide, informed, structured, and my baby, the key decisions and generation of ideas for the intervention happened primarily within the development team. The other 3, the delegated design, creative partnership, and negotiated design, the design decisions and ideation and development of ideas for the healthcare intervention were taking place outside as well as within the design team. So the informed design mode was a very common mode. It tended to focus more on explicit forms of knowledge. So people drew heavily on their literature reviews. And there's a quote here of people talking about information. So it's informed design, and people talked a lot about information. And this team triangulated the information. And although they conducted stakeholder engagements, those were used as a resource and considered by the team alongside other sorts of information. And the actual decisions were made at sort of team meetings rather than at those stakeholder workshops. Structured design had a number of similarities with informed design, but was very much framed by pre-existing framework or theory, and people talked about working through the framework and perhaps matching components to parts of the framework or the theory. And they also might use that framework or theory to guide the other activities that they're doing. So doing the same activities, they might be doing a literature review, they might be doing stakeholder engagement, but those activities were very much framed by the theory that they were using. I suppose one of the things to say was that these are sort of ideal versions, and in reality we found that the structured design was one of the ones that people struggled with most. So some people worked very effectively with a framework or theory and found it really helped them. Other people, we heard a lot of people saying things like, I thought that the theory would help, but in practice the situation didn't quite match the theory that we'd chosen to use. And in those cases, trying to apply the theory could actually obstruct the process of the team. The My Baby example, I've said actually that was one example, but I was thinking about it as I was putting together the slides, and I thought about another very similar example where the intervention had come from the clinical practice of the developer. That other example, that it's a very small team rather than one individual, but that same sense of it being their baby was common to that intervention as well. And these were typically things that had arisen from somebody's clinical practice, but it could be from people's academic practice as well, and might have been something that someone had mulled over for quite a while, perhaps discussed as a possibility informally with colleagues over a period of time, but they deviated from the sort of accepted processes of intervention development. They didn't, as this person says, he didn't have patient and public involvement and didn't involve primary care. Having said that, although they'd broken the rules, this particular intervention was one of the most widely implemented of the interventions that were discussed in the interviews. So that having broken rules didn't seem to have been got in the way of the successful implementation of this intervention. So moving to the types of design where design is happening with people outside the core team, Delegated design was design where part of the design process was formally delegated to an external collaborator. And this happened typically among interventions that were using the internet. So thinking back to Horvath's work, some of the issues that they found would be relevant to this type of design mode. But it could also be in the context of, for example, an education package. The extent to which delegation happened really varied among the people who were delegating design. So some people had produced a very detailed design brief saying exactly what the components of the intervention should contain, and it was perhaps just the sort of final how it looked, which was left to the collaborator. Other people gave people a much broader scope for developing the type of intervention that they felt was appropriate for the particular context. But the development team almost always did give the external collaborator at least some idea about the context to the development and the things that they thought it would be important for it to include. Developments also varied in terms of whether those external collaboration teams and the main core development team were kept separate or overlapped. So some people talked about their collaborator taking part in stakeholder workshops, for example. People felt that doing delegation this way had a number of benefits. So the people who were used to developing this type of intervention would obviously have expertise in how to go about doing it. They might have ideas about the sorts of things that would work. But one of the things that was really important as well was that they felt that they had the experience in the field to know how to go about designing an intervention that would be more likely to be implemented. Creative partnership has some similarity with co-production, but the focus here would seem to be very much on the ideas. So it wasn't just about sharing the power for decision making, it was really focusing on how to enable people to feel able to be creative. And people talked a lot about using games and exercises. So this person in this quote talks about using the idea of a persona where which is intended to get people away from thinking about their individual situation, circumstances, and it perhaps enables patients and clinicians to work together in slightly more abstract terms. That seemed to be something that people had experience of in a wide range of settings, and people seem to speak very positively about. But I've used as the image for this mode people dressing up, and that other things that people talked about doing was wearing a baseball hat to be, as they said, but to actually wear a different hat, and to be, the people were grouped into different teams, and one team might be representing a tech company, another might be representing a supermarket, and they had to think about how, if they were from that organisation, how they would go about developing an intervention. So they were using approaches to try and be more creative about how they were thinking about that intervention. And negotiated design was about operationalizing an intervention. Often the intervention's already been developed to a certain extent. So as this quote shows, in this context, they'd already developed a program theory, and they now wanted to operationalize it to particular circumstances. And this very much felt like there was negotiation happening between the academic team's vision of what the intervention should be and the delivery team's ideas about how that might be feasible and practicable and acceptable in their clinical practice. So cutting across these different design modes, we identified 3 themes and challenges for design and development. Working with different kinds of knowledge, stabilising the development to enable design. By stabilising, we meant developing clear shared understandings of what the development was doing and where you should go with it. And recognising and enabling creativity. Oh gosh, I've just checked the time, I'm going to go over. So working with different kinds of knowledge, we identified that doing intervention development involves working with formal explicit knowledge in the form of things like literature reviews, and informal tacit knowledge, that practical experience of living with conditions. And those different types of knowledge don't come in directly comparable formats. So teams have a challenge to know what to do when the knowledge seems to be pulling, different sorts of knowledge are pulling in different directions. So in this quote, the developer is talking about how they'd done a review, they'd done some initial talking to stakeholders about what the intervention should look like, and they were very clear based on that work that the intervention shouldn't include some work with families. However, they went to the PPI group, and the PPI group were able to argue back that it should. So in that case, the sort of tacit knowledge of the patients completely overturned the more formal explicit knowledge. Another challenge to do with working with different forms of knowledge was whether and how to try and translate one sort of knowledge into another format. So that can be both people trying to take the results of a literature review and take it into a stakeholder workshop, and the other way around, so trying to take the outcomes of the stakeholder workshop and take that back to a team to work with. That created challenges as well. Stabilising the development to enable design was one of the first things that kind of jumped out at us about the design, why the design process was worth some attention. So projects often talked about a phase during development when they seemed to go around in circles, everything was chaotic and messy, and they just couldn't move forward. And it troubles me a bit that this quote here is from a PPI co-applicant who doesn't no longer fully understands where they're going, what they're doing with the intervention development that they were part of. The idea about this being instability had come as we were conducting the analysis, but when we looked at the literature, it's very similar to the concept of equivocality, which there has been some research on. So Frishimar did some research looking at the activity of engineers and talked about how the engineers tended to deal with challenges in the development process by trying to reduce uncertainty, so going out and collecting more information rather than really dealing with the problem of equivocality and trying to reduce that. And Frishimar says both need to happen to enable effective design to take place. Teams did lots of things to try and deal with their instability. It's obviously uncomfortable if you're taking part in the project and it doesn't feel like it's moving forward. And one of the things project leads often seem to do was draw back and sort of reduce the size of the team to try and work with people who had a shared understanding of what they should be doing. But what other people in the team said about that was that then they worried that they were now losing key perspectives on the development, and those dissenting voices might actually be contributing something important. Things that worked more positively to stabilise, people could act as a stabilising factor. Designers, as in art and designers, could stabilise, but that could be personal dependent. And one person I spoke to had experience where a developer had been destabilising because they couldn't work effectively with the project lead. And working together to produce programme theory could also be a really helpful stabilising factor. Recognising and enabling creativity was the third theme that we identified, and we realised that when we were talking to people about their intervention developments, they really varied in the extent to which they talked about ideas and creativity. Often people talked about their development more as decision making rather than as a creative process, and that depended a bit on the mode that people were using. Those in the informed and structured modes tend to maybe talk more about decision making, so they might have looked at the existing evidence and identified components that were effective elsewhere and brought them in as components of their intervention, rather than particularly trying to generate new ideas. Whereas people in the creative partnership and My Baby mode did talk much more about how the place of ideas in their design. A designer that we included as one of our past participants suggests that this is because the language used in design and creativity doesn't sit easily within the sort of health intervention development methods. It's not, as they say, a replicable process and a rigorous one. So it doesn't sit comfortably with other development processes. So we looked at what other people were saying about design. Nonica has looked at, there's quite a lot of research, although there's not been a huge amount within health intervention development, a lot of research has happened in other fields. And Nonica had looked at activities in a commercial setting and working in organisational research, and had identified 4 different ways that knowledge is converted in the design process. One of the important things in terms of thinking about health intervention development is that other people have taken Nonica's model and identified that certain modes, certain types of knowledge conversion are more likely to result in innovative ideas. So tacit to tacit knowledge and explicit to tacit knowledge was more likely to generate innovative ideas than tacit to explicit or explicit to explicit. And those explicit knowledge, again, is those ones that perhaps current guidance has focused on more, like the evidence synthesis. I was also really interested in some work that Mary Dixon Woods had done as part of some work on quality improvement, looking at the terms that ancient Greeks had for knowledge, and they seem to identify different sorts of knowledge in different ways than we're used to thinking of it today. Mary Dixon Woods suggested that a problem with a lot of top-down state interventions is that they prioritise scientific knowledge and undervalue that sort of contextual tacit knowledge. But thinking about in the context of index, in general, it seemed that it tends to work the other way around, and people are, as with the example of the PPI group that overrode the findings from the systematic review, people seem to prioritise that stakeholder perspective more. A slight warning on that is that stakeholders maybe have a tendency towards being conservative when presented with a new idea, and people also talked about having it when they worked with stakeholders over a period of time. It wasn't unusual for stakeholders to change their minds and become more positive towards some of the ideas that are being presented. And I was troubled by some of the accounts that I heard where what might have been a promising idea had been left at the drawing board on the basis of quite strong negative feedback from stakeholders. And this quote below is from someone who works doing implementation of healthcare interventions and has acted as a stakeholder in intervention development groups. And at the start of the interview, they gave an example of how they are giving a sort of a perspective on the reality of what's feasible in routine clinical care. But then later on in thinking about their role in implementation, they talk about how actually they hear these accounts of how things aren't feasible, and they can work to overcome those feasibility issues. So although this is really just to say, although I think it's absolutely essential to engage with stakeholders and to access that tacit knowledge and experience, it might be worth sometimes trying to take some ideas through to the feasibility stage, rather than if it's felt that that's a key potential part of an intervention, rather than giving up at that drawing board stage. We also had to look at some work on a methodical development, and this was the idea that actually, although people talk about using a particular approach and methods, they're just saying they're doing that, and what they're actually doing in practice is very different. And I think we found some evidence that that does happen. So the top quote here is from someone saying that we constantly say we use the MRC framework, but actually we don't really. And this person went on to say one of the problems that they had is they felt nobody was really that interested in using methods in intervention development. And the second quote here seems to bear that out. This is from someone who's clearly not that interested in engaging with the detail. He or she just wants to get on and do it. So they talk about that they just did it. So conclusions, the focus in intervention development has been very much, I think, on the building blocks. So identifying and using evidence, stakeholder consultation and theory, and less on how you actually work with that the information and the knowledge that you get from those building blocks to produce an intervention. And perhaps there needs to be more of a focus on how people can use these different forms of knowledge effectively to maximise creativity and hopefully develop interventions that will be effective and go on to be widely implemented. And I just want to say briefly something as well about to encourage other people to consider doing qualitative research about development. I think it is worthy of attention, and one of the things it might do is help to create a clearer and more comprehensive account of what's actually happening in intervention development. And as one of the quotes said before, not just losing the discarded ideas, but actually having a way of retaining them, perhaps using them in other more appropriate contexts. Qualitative research is really good at problematizing processes, I think, and it could be quite useful to have qualitative researchers asking people tricky questions about why they're doing the actions that they're undertaking. And perhaps qualitative research might be able to help improve intervention development processes in the way that it has done, I think, for evaluation processes. I'm thinking about things like the work that's done by the Quintet team and others to help improve recruitment to clinical trials. That there may be, as more people working in this area, there might be ways that qualitative research could contribute to the intervention development endeavour. These are the existing papers about index, as well as the ones I've mentioned already. We have a paper under review led by Eddie Duncan looking at reporting guidance. And I've also included some references, but most of these are in the paper, the design paper as well. Thank you.
Okay, can you hear me, Nikki?
I can hear you, and I'm really sorry, I know I've gone over.
Well, I think I'm a little bit guilty of that as well, because I was listening so intently I wasn't keeping track of time myself. And I just wanted to firstly say thank you. That was so comprehensive, such a clear explanation of something very complex. You're looking at the complexity of using qualitative research initially, and then also the complexity of the topic itself, how people develop interventions. And you explained it so clearly. So if I don't have any questions from the group, and a lot of people were listening in today, if anybody does have any questions, could you please post them now? I'm getting a comment, hugely beneficial. Thank you so much. I will agree with that. Another one, thank you very much, Nikki, for this, very comprehensive. So it's all good. You may not have that many queries, and even myself, as I was listening, I had questions, but then you answered them in a slide or two later. So yep, superb webinar. I might have just a comment rather than a question, Nikki, and it's more about, well, firstly, I really valued the way that you brought in discussions such as the PPI discussion, the discussion around ethics. That doesn't often come up as much in this area of qualitative research. So I was really pleased to hear you talk about the ethics, and particularly when interviewing key stakeholders and things like that. Still, I have another sorry, I'm half distracted because I'm looking a few more comments about how excellent it was rather than actual queries. You mentioned when you did your own analysis of the interviews that you started with thematic analysis, but there was an element of theory use. I just wondered if you could talk a little bit about whether you found incorporating a theory valuable or not, particularly in the broader context of using theory in intervention development, but in your own qualitative work.
So I suppose one of the ways I was thinking that we deviated from thematic analysis in the Braun and Clark sort of, they've now differentiated between several different versions. And we did use a coding frame and applied codes at a relatively early stage using NVivos. We, as a team, we all looked at transcripts and we developed a coding frame, which I then applied, although it did develop considerably as I was going through coding all the transcripts in NVivo. So that was one of the ways that I think it deviates from some sort of some versions of thematic analysis, that we did have a coding frame that we used, and that the coding and labeling was about trying to identify bits of the data pull out, and the development of the themes. Some of it happened during that phase. So I think the theme around stabilization happened very early on. It was so strong when people were talking about that frustration, that sense of going around in circles, that emerged very, very quickly. And I suppose actually that's quite a good example of how we then, when we looked at literature, we found that there was work done around equivocality from other fields. And the theme that we'd identified around stabilization mapped very well onto that theme, onto that concept of equivocality that other people had used. So I think that's how we were using it. We were more sort of, we'd got a concept, and then we wanted to see how other people had thought about similar things. We didn't want to reinvent the wheel. We wanted to add to existing research, and I suppose that's theory gives you one way of doing that. So I think we're using theory as that sort of tool for thinking to help us sort of extend and develop our analysis, rather than as a sort of a frame.
Yeah, perfect. That's lovely, Nikki, and really reflects my own thoughts on theory use. There's a few questions have come in now. I'm conscious of time, but I'll try and get through them. There's two, again, more comments rather than questions. Thank you, really informative. Thank you, Nikki, very comprehensive and informative. So thank you for all your nice comments. And now we have some actual questions. One from Alison from Sheffield. She says, have you come across any challenges around getting ethical approval when planning to use the mixed consent model? Now, my thought is that you haven't used the mixed consent model yet. So I don't know if you've read anything about that question.
No, I mean, as I say, the person I know who's used it is Penny Hoare, and she very kindly shared a information sheet that they'd used in one of her studies with me. But I can't, I'm going to try and find out whether she's actually talked about it in any of her papers. I've had quite a look, and I haven't been able to find anything.
And maybe you could let me know, and I could direct the community.
I do definitely feel, I mean, I think she feels very strongly about co-production, and I did feel like when I was doing the interviews, a lot of people are so knowledgeable, and I'm really just sort of borrowing I felt like I was borrowing their ideas some of the time, and it would have been, I think it would have been nice to have been able to, for them to have had that recognition that they were the origin of some of the ideas that have fed into Index. But we didn't really think about it until we were partway through, and by then it wouldn't have been fair, I don't think, to have changed to a mixed consent model, because then we wouldn't have given those people at the beginning the opportunity to be nice. So
great idea though for the future.
Yeah, I think so.
Another question from Sally Ann. have found in patient focus groups that there is a lot of agreement by patients with this researcher slash clinician's ideas. Difficult to get the truth sometimes.
Yeah.
A sense of maybe being eager to please. Have you any thoughts on that, Nikki?
Just that, I think this is where sort of maybe using some of the approaches from design, and by design I mean the sort of art and design and the games, and just helping people get away from their everyday way of thinking and perspective, and using their experience rather than reporting their experience. I think sometimes when we engage with stakeholders, maybe sort of asking people about, to tell us about their experiences rather than to actually work with that knowledge that they have. And perhaps I think maybe that's what things like the personas do, is they enable people to be slightly detached from their personal experience, but using that knowledge that they have and applying it. So I don't know whether that's why the people that I spoke to who'd used those types of approaches were, or had worked with someone from an art and design background, were in general really positive about the benefits that it brought. So yeah, I think maybe if those sorts of techniques and methods and skills were more widely used, then you might get a bit more away from this, if patients are being sort of acquiescent. And the examples I gave of perhaps where clinicians' initial response is towards conservatism, it might have benefits on for both those perspectives.
Brilliant, thank you, Nikki. And your colleague Pat Hoddinott has just commented as well that focus groups tend towards consensus when seeking disconfirming is so important in the early stages of design. I am so sorry to the outstanding questions. I feel like we have run out of time. What I might ask is that anybody who has an unanswered question could email me at info@quests.ie with your query or your question, and I can liaise with Nikki and try and get those answers for you. Another query is around access to the slides. What we intend to do is publish the webinar on the Quest website, and the resources will be available to you that way. That might take us a few days, so bear with us, but they should be on the website soon enough. And with that, have you any other comments, Nikki?
I don't think so, but thank you very much, everybody, for participating and for your kind feedback.
Exactly, amazing feedback. I haven't come across the likes before in anything, so delighted with that, and a lovely attendance number as well. So thank you to everybody, and please keep in touch by maybe signing up to the Quest newsletter and visiting us on quest.ie. And again, another comment from Pat. Well done, Nikki. Great to have worked with you. And I will echo that, saying it's been great working with you on this webinar for the last few weeks as well. So we'll leave it at that, and thank you very much, everybody.